Hi all, welcome back to Emergency Medicine lecture series. One of the most important aspects in the emergency department is maintenance of oxygen saturation and SaO2 in the blood. For that, everyone should know oxygen therapy and the devices that are used to deliver oxygen in a given patient. Depending on the situation, the diagnosis of the patient, the amount of oxygen that the patient requires, there are different oxygen delivery devices. Some are low flow devices and some are high flow devices, but the division is just arbitrary. A high flow device can be used for low flow oxygen, low flow device can be used for high flow oxygen, but in a given specific situation, you need to use a specific device. So let us get into the video and let's know what are the indications for oxygen therapy, contraindications, complications, and what are the different devices that are available for oxygen therapy. I'm not going into mechanical ventilation aspect here. That will be dealt in separate lectures. I'm Dr. S. Prakash Babu, Associate Professor of Emergency Medicine at Karpag Vinayaga Institute of Medical Sciences and Research. So, adequate oxygen delivery will depend on a number of factors, mostly the inspired partial pressure of O2, also called as FiO2, alveolar ventilation, that is the amount of air that is entering the lungs per minute, pulmonary gas exchange, is there any problem with the absorption of oxygen into the blood, depends on the capillary-alveolar membrane, oxygen carrying capacity of the blood, which depends on the amount of hemoglobin present, the affinity of hemoglobin to the oxygen, and also the dissolved oxygen in the plasma. And finally, the amount of cardiac output that is being generated and amount of blood reaching the end organs. The easiest factor of all these things is the manipulation of partial pressure of inspired O2. This is where oxygen therapy comes into play in the emergency medicine. So let's look at the indications for oxygen therapy. As all of you know, most accepted indication for supplemental oxygen is arterial hypoxemia. A partial pressure of oxygen lower than 60 milliliters of mercury or arterial oxygen saturation, SaO2 also called as SpO2, which is measured less than 90% indicate a hypoxemia. Shock state resulting from hemorrhage, vasodilatory states, low cardiac output states, and obstructive lesions are all the indications. Hypotensive patients and those with severe trauma until tissue hypoxia can be effectively ruled out by definitive investigations is another indication. Hypoxemic patients who are in respiratory distress, hypoxemic patients following myocardial infarction with signs of acute heart failure and cardiogenic shock. In patients with myocardial infarction who are stable and their oxygen saturation is more than 94% will not benefit from oxygen therapy. Keep that in mind. So continuing with the indications, carbon monoxide and cyanide poisoning is an indication for oxygen therapy. Asthmatic patients who are hypoxemic at the time of presentation, cardiac arrest during resuscitation, patients with anaphylaxis, transfusion-induced lung injury are all the acute indications for oxygen therapy. And some there are chronic indications called ambulatory oxygen therapy, like a chronic obstructive pulmonary disease patient who are chronically hypoxemic can be put on home oxygen therapy or ambulatory oxygen therapy. Patients with cystic fibrosis, pulmonary fibrosis, and sarcoidosis will similarly require ambulatory oxygen therapy. Are there any contraindications for oxygen therapy? The most important contraindication is paraquat poisoning. This is the only absolute contraindication where giving oxygen will worsen the condition of the patient. The patient is in carbon dioxide narcosis. You have to use oxygen judiciously because when you give more oxygen, the carbon dioxide will be washed out, leading to hypocarbemia. The patients with carbon dioxide are mostly COPD patients in whom they are acclimatized to higher levels of carbon dioxide, which is the sole respiratory drive. When you wash out the carbon dioxide from the lungs and in turn from the blood, there is depression of the respiratory status and patients will be uptended, can go into coma. Prolonged high concentrations in neonates can lead to retinopathy of prematurity. You should never withhold oxygen therapy in a hypoxemic patient for the fear of complications. Steps to be taken to predict and manage complications should be in place. Vitamin E and antioxidants have proven to reduce the oxidative complications caused by oxygen therapy in adult patients. And first and foremost, let us look at what is the use of oxygen supplementation during cardiac arrest and what does the guidelines say about it. All of you know, goals of cardiorespiratory resuscitation are restoring energy to the heart and brain so that they resume functioning normally. Oxygen is vital to these goals. Blood flow is the limiting factor for supplying oxygen during cardiac arrest. Everyone knows that. By supplementing 100% O2 during cardiac arrest, the dissolved hemoglobin can be increased, leading to better oxygenation. Supplemental oxygen during post-cardiac arrest care. Need to provide 100% oxygen initially and then titrate to a target saturation of 94% as early as possible. Otherwise, you are going to increase the generation of oxygen free radicals and thus oxidative damage. Avoid hyperventilation. ACLS repeatedly says avoid hyperventilation. At the same time, do not put the patient in a hypoxemic state. Saturation of 100% corresponds to a PaO2 anywhere between approximately 80 millimeters of mercury to 500 millimeters of mercury. So this is very wide range. Reducing supplemental oxygen when saturation reaches 100% is an optimum approach. So let's look at what are the devices that are available to you to deliver oxygen. As I told earlier, division into low flow and high flow devices is actually very difficult and it's just arbitrary. Depends more on the source of oxygen flow, the rate of oxygen flow, but not the device that is applied. Flow rates, delivery of oxygen at flow rates less than that of patient's inspiratory flow. You call it as a low flow device. High flow rates that match or exceed the amount of inspiratory flow of the patient are classified as high flow devices. Nasal cannulas, the prongs deliver constant flow of oxygen that accumulates in the nasopharynx and acts as a reservoir for oxygen. These device of nasal cannula, these two cannulas will go into the nose and this is the port for connecting to the oxygen source. The FiO2 that is delivered depends on the respiratory rate to which it varies inversely. If the respiratory rate is very high, FiO2 decreases. The tidal volume, the pharyngeal geometry, and the O2 flow rate. Nasal cannulas are generally set to 2 to 4 liters per minute and especially useful in patients who require very low levels of oxygen like COPD patients. It provides approximately 30 to 35% of FiO2. The problem with nasal cannula is on prolonged usage it can cause nasal dryness and irritation. Use humidified air as much as possible. The next device is a simple oxygen face mask. It receives a constant flow of oxygen from an oxygen source. During inspiration, oxygen is enriched air concentrated in the mask enters the lungs, and during expiration, about 200 ml of exhaled air exits through the vent pores. The remaining accumulates within the mask as reservoir. Oxygen gets concentrated in the mask before the next inspiration due to a constant flow of oxygen from the source. The determinants of FiO2 when you are using a simple oxygen face mask include the volume of the mask, tidal volume, respiratory rate, and again the O2 flow. At flow rates of about 10 liters per minute, FiO2 is approximately 45 to 65%. The flow rate is increased to 30 liters per minute. FiO2 increases to 80 to 90%. But the normal flow meters that we will be using cannot measure more than 15 liters per minute of O2, even though you keep the button and flush mode. As minute ventilation and inspiratory flow increase, FiO2 will invariably decrease. Indications for oxygen face mask is patients needing more than 2 liters of O2 to less than 8 liters of O2 per minute. The next device is the non-rebreather mask. It incorporates a reservoir bag that reduces entrainment of environmental air. There can be a partial non-rebreather and a complete non-rebreather mask. The partial non-rebreather mask increases the delivered FiO2. Non-rebreather masks have a series of one-way valves preventing mix-up of air. Outside air and the exhaled gas remaining in the mask dilute the O2 from the reservoir, and it prevents the mask from providing 100% O2. Oxygen flow to the mask should be sufficient to prevent collapse of the bag during inspiration. It delivers an FiO2 of approximately 70% when you set the flow to 15 liters per minute. Indications for a non-rebreather mask include pulmonary edema, chronic airway limitation, cluster headaches, smoke inhalation, and as a treatment for carbon monoxide poisoning. The next device is Venturi mask. The main advantage of an Venturi mask is titratable oxygen delivery, used more frequently in inpatient and intensive care unit rather than in the ED setting. The primary advantage is that FiO2 can be precisely controlled between 21% to 35%. Room air is pulled into the system through the entrainment ports and mixes with the O2 provided from the O2 source. FiO2 is constant and is determined by the velocity of the O2 jet and the size of the entrainment ports. So this is a picture to show the Venturi mask. There is a tubing, there is a mask, multiple connectors are there, and then these are the color coded actual Venturi mask controllers, where you can use FiO2 will be given on each of these ports, and you can use the exact port where the amount of FiO2 you need. Again, as I told, the amount of FiO2 that is delivered depends on the size of these entrainment ports. Though if the size is less, the FiO2 delivered will be more. The size of the entrainment ports is more air mixes from outside, so the FiO2 delivered will be less. The mask is continuously flushed by high flow of gas, which prevents the accumulation of exhaled gas in the mask. Venturi masks are packaged with multiple inserts, each with a different size orifice for O2 flow. FiO2 is determined by selecting the appropriate colored insert and the O2 flow rate according to the manufacturer's instructions. FiO2 may be significantly reduced with high inspiratory flow rates, especially in patients with respiratory distress. Next, most commonly used and which has picked momentum during the COVID pandemic is the high flow nasal cannula oxygen. It is the delivery of heated, humidified oxygen at high flow rates of about 60 liters per minute. Nasopharynx acts as a natural reservoir that refills with oxygen after each breath. HFNC requires three components mainly: a wide bore nasal bronch to deliver the amount of oxygen, jet oxygen that you are giving, a humidifier, and a gas delivery device to control the flow. It is better tolerated by patients than a face mask or non-invasive ventilation. So the picture here shows the setup for a HFNC. There is a humidifier here, and this is a machine which creates high flow rates. Commercially available HFNC systems use flow rates of 5 to 40 liters per minute. At flow rates of 15 liters per minute, FiO2 is 70 to 80%. If you increase the flow rate to 45 liters per minute, FiO2 increases to 90% or even more. HFNC additionally provides low levels of positive airway pressure, which range from 1 centimeter to 3 centimeters of water. So patient tolerability will be very high. Indications: respiratory support after extubation, especially in neonates, for management of respiratory diseases in neonates, COVID-19 patients with respiratory distress, immediate intubation is not required, and patients following a cardiac surgery, HFNC is proven to prevent invasive ventilation. So let us look at the procedure for oxygen therapy. That is how you are going to select a device in a given patient to deliver the oxygen therapy. You need to consider the clinical condition of the patient and the amount of O2 that is needed. Venturi system should generally be used for patients who need precise control of FiO2, like COPD patients or patients with chronic respiratory distress. Nasal cannulas and face masks are set to deliver lower flow rates. Patients with significant hypoxemia, end organ dysfunction, or respiratory distress require a higher FiO2 delivery system. Frequent clinical assessment and blood oxygen saturation (SpO2) monitoring are needed in all patients receiving oxygen therapy. Equilibration of SiO2 after changes in supplemental O2 occurs within 5 minutes. FiO2 should be titrated to achieve therapeutic goals while minimizing the risk of complications. An SiO2 of 90 to 95%, which corresponds to a PaO2 of 60 to 80 millimeters of mercury, is an appropriate target for most patients receiving supplemental O2. If you are targeting FiO2 more than SiO2 more than 95%, there is every chance of free radical damage. Finally, let us look at the complications due to oxygen therapy. As I told earlier, in COPD patients, CO2 retention leading to progressive respiratory acidosis and apprenticeship in patients with COPD. Oxygen-free radical injury, worsening ARDS, brain damage, retinopathy in neonates. Absorption atelectasis due to replacement of nitrogen in the alveoli can happen, but fear of toxicity should not prevent the use of O2 when there is specific indication. Use the minimum concentration of O2 necessary to achieve the therapeutic goals. Thank you. Put on your own oxygen mask before assisting others. Thank you. Don't forget to share and subscribe the videos.